Hello everyone, welcome to the Voice of Nursing. My name's Adrian Tracy, I'm CEO of ICG Medical. Today we are joined by Lizzie Chambers. Lizzie, welcome.
Hello. Nice to be here.
Lizzie, tell us a bit of background about what you do.
So I am Director of Research and Programmes at a national charity called Together for Short Lives. So we're a charity that's all about children's palliative care. We're a membership organisation for all of the children's hospices, children's palliative care teams in hospitals and community teams as well. But that's our role, and I've been there for nearly 18 years, so it feels like a lifetime.
Seen some changes in that period.
Yes. No, it has changed a lot since I first started. I think, in the very early days when the sort of children's hospice movement was first setting up, for example, their model was very much based around sort of planned short breaks for children. But I think as children's needs have got more and more complex over the years, they were having to look at that model again. Look at whether they should be focusing more on complex care and symptom management for those children. Mm-hmm. So yes, it is changing as we speak.
What is the focus of the charity now? I think many people would have heard of it, but what's the actual focus there?
So we have, I guess, three key things really. One is around the support we provide directly to families. So we have a helpline, which is increasingly busy. We have support for families through things like online groups, Facebook group, that kind of thing, and just producing resources for them as well. Mm-hmm. We then have a programme of work around supporting the professionals who work in the sector. So it's kind of best practice resources, things like our care pathways, just bringing people together in the sector really to talk about best practice. So mm-hmm. different professional groups, they might be sort of nurses in hospices or there might be sort of people working in social care, bringing them all together. And we then have a really important strand, which is around sort of influencing and policy. So we do a lot of public affairs work and events in Westminster and all that kind of thing.
Interesting topic at the moment.
Yes. We were up there on Tuesday. We had one of our all-party parliamentary group meetings in Westminster, and it was quite hairy. Lots of shouting outside, but we got the minister there, which is good.
That's a good effort.
Yeah.
And talk us through some of the areas you're focusing on. In the sort of there's like some guides coming out you mentioned.
Yeah. So we produce a lot of guides, but this year's guide is it's about end of life care. So it's guidance aimed at professionals, particularly those who don't perhaps work in children's palliative care. But really to support them have those difficult conversations about the fact that a child's going to die and the need to make plans and to have just open, honest communication really. So we've got a guide for professionals about that, and then a guide for parents that kind of mirrors it, so they can talk that through with parents as well. Just so that families know what their choices are around things like organ donation or where they want their child to die. Difficult decisions about treatment, that kind of thing. Mm-hmm.
Difficult conversation.
Yes. So we're really pleased with them. They're coming out in the next month or so.
Okay. And are they online? Are they available?
They will be online.
Excellent.
Hard copy as well. So yeah, we just sort of want to promote those as widely as possible because I think the thing with palliative care is that it's not just a sort of specialist thing that people do in specialist roles. It's kind of everybody's business really. Everybody knows somebody who dies in their community. I know the research we've done shows that at least one child in every school will probably die, so it's actually quite common. So it's really about empowering people to have those conversations and not be so scared of talking about death. Mm-hmm.
So the Director of Research and Programmes, what does that role cover then? So that sounds quite expensive.
It does sound quite expensive. So a lot of my role is really working with people out there in the sector, so particularly with people who are researchers. Mm-hmm. So we have a whole range of different universities that we work with, partnering with them on their research projects. I think often we're asked to be involved because we can kind of enable access to families as well. But we've also commissioned some pieces of research ourselves. So for example, we commissioned a study around the prevalence of life-limiting illnesses in children. So our statistic that we use often is the 49,000 children.
What was that?
So that was with the University of Leeds at the time. It was Dr. Lorna Fraser who carried out that research. and she's just doing an update as we speak, actually, that's going to be published in March, because we know the numbers are definitely going up. The children are living longer. Babies are surviving kind of birth and surviving into toddlerhood. And it's important for service planning to know those numbers as well.
Yeah.
And then I think the next piece of research we want to do is really looking at, of those, that big pool of children, how many have active palliative care needs, so how many need palliative care now. Mm-hmm. So that will be the next thing that we're looking at.
And what do you sort of see as the biggest challenges in that space?
I think with research, one of the problems is professional gatekeeping. So we find often when we've gone out to try and recruit families for research, professionals sort of want to protect them, worry that they won't want to talk about death and dying with somebody. But in fact, families do. We're also aware there's a real lack of research in this field, in children's palliative care. And so it's prioritising the good research there is and trying to really develop collaborative working. Mm-hmm. With such a small number of academics in this field, it's finding ways to bring them together and work together on research as well, mm-hmm. which is something we're hoping to look at more.
Mm-hmm. And also then looking into the actual industry sector, then when you're speaking to these hospices and speaking to the palliative care, the people who are offering the service, what sort of challenges do you see that they're facing? Because I'd imagine burnout must be pretty high, mental health must be pretty difficult.
Yes.
If you're dealing in those situations. There's some, hopefully there's some good news stories, but obviously there's some tough situations to deal with.
I mean, I think the thing that surprised me most when I first sort of started working in this sector was just kind of how uplifting it was. Because you think it's all about death, it's all about dying, it's pretty grim. But actually it is all about celebrating life and making the most out of life and quality of life. It's got really sad bits as well, but it actually, and that's why I've stayed so long, I think, because it's really quite uplifting. I get all teary when I talk about it. So that's the thing. But I think one of the problems we have got is around workforce. We don't have enough nurses to staff beds to carry out the care that's needed. Don't have enough doctors, don't have enough community nurses, we don't have enough hospital teams, we don't have enough of anything. So the sustainability of that is a worry. And we know that the kind of workforce is ageing. A lot of the key nurses and advocates in the sector are approaching retirement age. So it's getting that next generation in is a challenge.
Tell me some of the success stories or some of the fun that the young ones have been having. You've been there a long time, you must have seen some interesting stuff.
Yes, so we one of the things we did was it was a transition programme, and we kind of worked with lots of young people who we called our young Avengers. They wanted to be called that, by the way. And that's been great. We've actually in the last couple of years we set up something called our Improving Transitions for Young People Fund, and we funded 10 projects to develop kind of innovative approaches to transition. But we were really keen to fund at least one project that was just working directly with young people. And one of those was around really enabling young people to be able to talk about relationships and sexuality. Mm-hmm. So that's been a bit of a hoot.
Okay.
No, it's been great working with those young people and just giving them a voice really to talk about this because it's such a taboo.
Yeah, okay.
You expect young people with these really complex health conditions to just be sort of sitting in beds and, being ill.
They're still young
but
people.
They're young people and they want to have relationships and they want to, do all those kind of things. Mm-hmm. So it's just been really quite refreshing talking to those young people.
What sort of outcomes are you coming out of that?
I think...
Must be hard to talk to the parents as well, I suppose.
Yeah, it is quite hard. I mean, we haven't really done so much with the parents. But basically, their message is, we're just like other young people.
Yeah.
It's just harder for them to get out and meet potential partners, so it's quite difficult. But we have worked with one young person who's married and, so it's can be done.
And I know some of your current projects, you've got the Improving Transitions for Young People, and you've got the Pathway Clinic.
Yeah, no, we've done a lot of
the
work
umbrella
on,
of care, I think.
yeah, a lot of work on this transition issue because it's just such a growing issue. I think our data study we did, there were 15,000 young adults. I think it was aged 15 to 30. So it's quite a big number of young people. And adult services just really aren't equipped or don't have the knowledge and the training to be able to deal with them well. Often it's conditions they've not heard of. They're quite rare conditions that they won't have come across. They won't be familiar with treatments and all that kind of thing. And just talking to young people, they're not very skilled at that either. We had one story of, it was a young person who'd gone into an adult hospice. And she said it was just all sort of China teacups and, afternoon tea. And
Right.
yeah, she just wanted like pizza and, it's just they're not equipped for young people, basically. So we've got a whole range of things there. We've got kind of hospice to hospice programme, so children's to adults, hospice transition. We've got some which are more looking at hospital provision. So we've got one down at the Royal Devon and Exeter Hospital, which is looking at running kind of a carousel clinic where all the different ologists in adult services come together when the young person's in the clinic, and they have their appointment with everybody there rather than 15 different appointments. We've got a project with the Council for Disabled Children, which is doing a module of their expert parent programme looking at supporting parents of these young people, because so many of them have profound and multiple learning disability, and parents have kind of been their advocate all the way through, and then they get to 18 and suddenly then it's not automatic that they're consulted about what their young person's wishes are. So it's really preparing parents to that new role, what they need to do in terms of decision making and paperwork around that.
What happens in that situation?
Well, it's really quite tricky. I mean, they usually it would be it would be kind of set out in the paperwork that the parent is the decision maker for that young person. But it does change literally overnight when the young person becomes 18. Suddenly it's not automatic that the parent is kind of involved in appointments with their young person, and so you have to kind of negotiate all of that. So a lot of transition planning is about that kind of preparation for that role changing.
I was going to say, is that quite hard for the parents?
It is really hard. It is really hard, and it's these young people are often very fragile and vulnerable as well. So they obviously are very protective of them.
Yeah, of course.
So it is really hard for parents. So we've been doing a lot of work on transition. I think it's something that really interests me. I think it's a kind of growing field, really.
Yeah.
It just wasn't there before because these young people didn't survive.
No, they would die, unfortunately.
But it does mean that services are needing to look at their models and think about how they make them fit for purpose for young adults. Some children's hospices, for example, have had to, just because of resources, have had to sort of cut back the age of the people they support. So some have now cut back to 18. So the issue there is about then working with adult hospices to make sure there is a smooth process.
So don't move them out straight away when
they're
they're 18 and straight in. And
that's right.
Also must be quite upsetting for the young person as well, moving straight into that.
Yes. But it's also not just about the health, it's about the whole, we call it the pentagon of support, but it's that whole, their social care, education, housing, employment, or volunteering, or, it's looking at the whole of that young person's life as well, so that they're having quality of life.
And then you've got two other key resources you work with, guidance for neonates and then technology-dependent children? We kind of span 0 to 25 is how we define our sort of client group. So we have done quite a bit of work around the kind of perinatal population as well. In fact, I've just come from a meeting with the Pan London nurse for neonatal palliative care, which has been interesting. But we've produced a perinatal care pathway, and we've done lots of work with sort of Bliss and some of the other sort of baby charities.
around this.
Tell us a bit more about that.
So the perinatal pathway, it's so we produce a lot of pathways. I think we've got 5, and the perinatal one, it's a kind of baby and family centred pathway through services with kind of standards along that pathway. So it's really just about supporting, I guess, people in neonatal units just to have more confidence around decision making, around stopping active treatment really for babies. Just talking about palliative care in a more open, upfront way with families. Thinking about whether the family and the baby would benefit from being referred to a hospice or to a palliative care team for support. So it's lots of standards around sort of conversations really.
Right, okay.
Yeah.
Must be a very difficult conversation.
It is difficult. It is difficult. But there are, it's just best interest decision making for those babies really. If they're not going to have quality of life, or if you're kind of keeping them alive artificially, will they be able to come off and breathe for themselves, or and that whole ethical debate of just because you can, should you?
Right.
So a lot of our perinatal pathways around that kind of thing, and
how does that come about then? Those decisions that is the right path. Is that just a number of doctors getting together having a conversation?
Yeah, a mix. Or? So often it'll be a multidisciplinary decision really. So doctors and the nursing team, and obviously with the family as well. The idea of having it as a pathway, so that it's not a big rushed decision. It's something that you've taken time to bring people together and consult over. And obviously it doesn't always happen that smoothly. There have been high profile cases where it's not gone that smoothly. Yeah. But it's often because the conversations aren't had, those honest conversations haven't happened. It's all about trying to sort of build that in as part of normal practice really, not just at the end. Yeah.
And what's the technology dependent children?
Well, we have another one of our pathways is the extubation pathway. So that is when children are on sort of ventilation, long-term ventilation, which basically breathes for them. So these are children who would have died basically without this technology. But it's about just supporting decision making around removing that equipment from a child, and how to do that sensitively and in the best way. So quite a tricky area, but again, it's about honest communication with families and how you can potentially take a child who's in a hospital setting or perhaps been in there for a really long time, enable them to go home, remove the equipment, and they can die at home, have a much more peaceful death. So that's what that pathway is all about. Jolly stuff.
I was going to say. Hey,
back to the uplifting.
Yeah. And you've recently taken a new role, a co-chair of the New Children's Task Force, working with the European Association for Palliative Care.
Yeah, we've done quite a bit of work internationally because a lot of the first consultant in children's palliative care is here in the UK.
Okay.
So Dr. Anne Goldman, who is at Great Ormond Street, was the world's first consultant, and children's palliative care just sort of grew here first. So we are seen as quite leading in the sector. But I co-chaired the International Children's Palliative Care Network with my colleague Barbara Gelb at the time. So that was an international group all about children's palliative care, and we did that for quite a long time, about 7 years. And then after that, I now co-chair the European Association of Palliative Care's Paediatric Task Force. And we had our first ever full-day session at their congress in Berlin last year, and it was amazing. Had 1,000 delegates. So we're hoping to really build on that and really just build palliative care, across the world as well.
And what were your observations about how different countries treat it differently or look at things slightly differently?
Yeah, it's interesting because it doesn't always follow that those resource-rich countries provide better palliative care. And they might have better resources and more equipment and facilities, but we've been talking, so much of palliative care is actually just about conversation, and you don't need money to do that. So a lot of the approaches in less resource-rich countries are more kind of community-based.
Okay.
It might be supporting people in the community to, support others and have conversations. So,
which countries would you think?
Well, we went to visit some work, a project in India where they trained up kind of local women in the village just to support other families in their community. And it just seemed to work really well. It wasn't rocket science, but it seemed to really work. And there's so much we can learn from that, I think, as well.
Right, okay.
We've kind of got almost, a bit obsessed about all this equipment and technology and almost lose sight of what quality of life is.
Yeah.
And just supporting, the community to have a bigger role as well. So that's maybe what we'll do next year.
Start talking to people. And what you saw, and then what is European? Did you see the Europeans and the Americans? Because obviously different types of health systems as well.
Yeah, no, it is interesting. It's funny because in the UK we've got so many sort of building-based sort of types of provision for these children. Lots of sort of children's hospices with buildings, which they don't necessarily have in the States or in European countries either.
Okay, what do they have?
Germany has quite a few, bizarrely, but
right.
It's more kind of hospital teams with kind of outreach into the community, that kind of model.
Okay. So what, like a children's ward or something?
So kind of hospital specialists and nurses around them and doing outreach into the community. Not so much the kind of hospice model which we've got here. But I think it's interesting, all models work and have their benefits. So I think a thing for our European group is to try and sort of learn from those different models and what does really work, and try and find out a bit more about that, really.
And what key points do they take from our system? Is there anything that they turn around to you and go, oh, right, we should be doing that?
What we've spent quite a bit of time doing is developing sort of definitions, standards, kind of advocacy tools that services can use. So lots of countries use the kind of categories of life-limiting illness that we've described, and I think it's about trying to, the challenge really is to try and make sure that countries see children's palliative care as not being just about children with cancer, or that they do see that bigger picture of need, and develop services to support that need as well.
And when you're looking into the palliative care, the hospices and that, and obviously we're a nursing channel, what sort of challenges do you see the nurses under at the moment? Or facing, should I say?
I think, obviously there's a big challenge in just workforce generally. The numbers aren't there, and so recruitment of nurses in the right numbers is really hard. For nurses who work in children's palliative care, it's it's the kind of support that they need in that role as well. So making sure there's adequate sort of clinical supervision and support when it's quite emotional work. Just sort of looking after yourself really in that role. I think I have heard that nurses do get quite burned out sometimes if they're not adequately supported. But it's a field, I think, that attracts a certain type of nurse, I would presume. It won't suit everybody, but I
think it's the emotion, isn't it? The emotional drain they must have on a daily basis.
Yes. So you have to be quite a resilient person, I think, to go into this field.
Yeah.
But lots of people will say, but also the uplifting side is, seeing these sick kids happy and laughing and having fun it makes it all worthwhile.
What do they normally focus on? What normally is the tick boxes
for
the kids,
for the children, for them being able to sort of lead a relatively normal life, go to school and see friends, and I guess just have their illness in the background, so it's not the thing that's on their mind all the time.
Okay.
It's difficult if you're stuck in hospital for months, even years, to be able to do that. But I think enabling them just to live a normal childhood.
Just be normal kids.
Yeah.
Have fun.
Yeah.
Lizzie, thank you for coming to see us today.
Pleasure.
Really appreciate it. Is there any message you'd like to give to our nurses?
Just any nurses, come and work in children's palliative care. It's amazing. And for those who do, thank you.
Thank you, Lizzie. Thank you for watching The Voice of Nursing. Thank you to all our doctors, nurses, allied health professionals and social workers. And we'll catch up with you again soon.